So I was wondering how I would say stop to Bhagavad. It's not my cup of tea. So I said, okay, I put that responsibility on Eunice's shoulder. So friends, today I'm going to talk about the current status of left main coronary artery PCI. Well, as you know, the LMCA disease has a significantly high mortality when the patient is kept on medical treatment as such. And we know traditionally over the years that CABG surgery was considered as the treatment of choice for LMCA lesions. Earlier, PCI was undertaken, but it was restricted to high surgical risk patients. But however, with the recent advances in the PCI techniques, the expertise, the hardware availability, and the intravascular imaging, PCI has become amenable because it offers quicker recovery, shorter in-hospital stay, and a similar long-term outcome as per the data when compared to bypass surgery. A word about the anatomical consideration of left main. As you know, it supplies almost 75% of the myocardium. It has got a large caliber. It has got a wide angle distribution as far as the supply is concerned. Is highly prone to atherosclerosis. Incidentally, it has got a higher stent thrombosis and restenosis rate. And the LMCA disease is frequently associated with multivessel disease problem as well as acute coronary syndrome. And you must understand that the LMCA lesions could be either confined to the ostium, the shaft, or it could be the bifurcation. Now, isolated LMCA lesions are seen in almost about 5 to 8% of the cases. 80% of the LMCA lesion involve the bifurcation. The lesion complexity is determined by the syntax score, which talks about the calcium, the length of the lesion, what the angle is. These are considerations which are taken by the syntax score, and it correlates with the clinical events. The current guideline recommends that if there is more than 50% stenosis in the left main, then you should offer revascularization, either in the form of a PCI or in the form of a CABG surgery. When you consider PCI, it could be simple, as Dr. Bhagwat said, could be a provisional stenting or a complex PCI techniques, and accordingly you decide what techniques are to be undertaken. When we talk about the LMCA lesions, there are certain things to determine whether the patient should go for PCI or CABG, and you look for the comorbidities as far as age is concerned, the frailty of the patient is concerned, obesity, diabetes, mellitus is concerned, concomitant aortic or valvular heart disease, prior radiotherapy, or a patient has chronic kidney disease or not. You look at the cardiac presentation, whether the patient has LV dysfunction, whether he's in heart failure or cardiogenic shock, and also whether the patient has multivessel disease. The anatomical factors as far as the lesion is concerned, you have to take into consideration whether there is multivessel disease, length of the lesion, location of the lesion, the distal vessel caliber and the condition of the vessel, and the plaque morphology and the burden, calcification and thrombosis, which can be best seen with IVUS. And you look at whether the patient has a recurrent or in-stent restenosis. Also, you have to consider whether the patient can be continued on double antiplatelet therapy or not, or whether there are any contraindications, and whether the patient has got a high bleeding risk. Now, this is the definition criteria to determine what is the left main bifurcation lesion, complex lesion or not. You look at the side branch length, lesion length, about more than 10 millimeters. Look for the side branch stenosis, which is more than 70%. And you look for the other minor criteria, that is moderate or severe calcification, multiple lesions, and the bifurcation angles, which is less than 45 or more than 70. And a complex coronary bifurcation lesion is if you have one major criteria and two minor criteria. And these are important when you decide what is the strategy you are going to adopt for patients who have got bifurcation stenting required. Now, this is the summary of the randomized clinical trials of PCI with the DES versus CABG. And there were about 6 trials, out of which the Syntac trial, the pre-combat trial, and the Excel and the Noble were important ones because they had significant number of patients. And all of them, it was a DES which was used, and most of the patients had bifurcation lesions, particularly in Excel and in Noble. And the outcome of this, when the primary endpoint was considered, which was death, MI, stroke, or repeat revascularization, it was for Syntac as well as pro-combat as well as Excel, it was found that PCI was non-inferior to CABG as far as the primary outcome was concerned at 1 year or 5 years or 10 years as compared to CABG. However, the latest trial, that was the later trial rather, which was Noble, it showed that PCI was inferior to CABG. And this is precisely what is showing that if you go to the primary endpoint and you look at the Syntac trial, the PCI outcomes were about 16% against 14% for CABG, practically matching but slightly better for CABG. So this was a hypothesis generating trial. So also was pre-combat, which was 9% against 7%. But in Excel, PCI was non-inferior to CABG. It showed about 16% to 15%, almost matching as far as the primary outcome was concerned. But Noble gave another side. It said that PCI had almost 28% outcome as against 19% with CABG. And PCI was inferior to CABG as per this trial was concerned. So as far as the strategies are concerned, when you have left main ostial or shaft stenting, PCI has a favorable long-term outcome compared to CABG. But when it comes to bifurcation, higher risk of repeat vascularization in the distal left main bifurcation lesions favors CABG over PCI. And this was consistent across the earlier trials and certain subsets of patients. Now, this is interesting to note that these are basically related to distal bifurcation lesions of the left main. The DK Crush trial 2017 and the EBC trial which Dr. Bhagwat spoke about, these were all having bifurcation lesion, and it was provisional stenting against DK Crush stenting. And in the DK Crush stenting, they found that the outcome was very, very favorable. It was about 11% for provisional against 5% for DK Crush. And for 3 years outcome, it was 17% against 8%. So almost 50% better than what it was with the DK Crush as compared to provisional. Where the EBC said that it was practically same at the end of 1 year. It was about 15% to 17%. So the consensus here, as far as DK Crush was concerned, it was much better for the bifurcation stenting. So DK Crush trial demonstrated that two-stent strategy has a lower rate of target lesion failure at 1 year and 3 years than the provisional stenting strategy. However, EBC main states that stepwise layered provisional approach was associated with numerically but not significantly fewer major adverse cardiovascular events at 1 year as compared to planned dual stenting. And this is definition 2 trial which talks about complex bifurcation lesions which are dealt with 2 stent, and in these settings a DK Crush showed that the outcomes were much better. Let us look at the role of IVUS in left main stenting. It can provide additional information on the ischemic burden of the left main lesion, provide more reliable information on the lesion characteristic than angiography, and helpful in planning PCI strategy for distal left main. Also, post-PCI, it ensures that the stent optimization with subsequent post-dilatation, if required, can be done, and also to identify procedural complications. The role of FFR is basically to provide accurate information on the functional status of angiographic intermediate or ambiguous left main lesions, or in post-PCI status to assess the flow in the jailed branches after the provisional stenting. And this is just a picture to show you how the OCT can also show you whether the stent is well opposed or not. And if required, you do a post-dilatation and get a well-opposed stent and good results at the end. By and large, in IVUS, if you have an MLA of more than 6 millimeters square, or for Asians, if it is more than 4.5 millimeters square, it's generally accepted as safe and the optimal cutoff value for differing treatment for LMCA disease. Intermediate LMCA lesion with FFR more than 0.75 or zero point 0.8 could be safely deferred. We await the results of the optimal trial to give us a proper indication or direction to use IVUS in left main PCI. You have to take into consideration the special populations, patients with diabetes, CABG as a preferred strategy associated with multivessel disease. However, PCI may be a reasonable option for non-complex left main lesions. Patients with reduced ejection fraction, LVEF, was independent predictor of 4-year mortality and showed moderate interaction on the effect of long-term mortality prediction, but CABG was slightly better than PCI. In elderly patients, if they have if they are frail, then the younger patient, then you consider PCI. However, patients less than 170, the 5-year risk of MACE was significantly higher with PCI as compared to CABG. In patients with acute coronary syndrome, they present with severe hemodynamic compromise and may require mechanical circulatory support. And the outcome of LMCA in patients who are in cardiogenic shock as compared to those who are not in shock or who have got stable coronary artery disease, the outcome was very, very bad. Now this is the chart in which how you proceed. If you have left main ostial or mid-shaft disease without bifurcation, then PCI is recommended. But if you have significant left main disease on angiography, IVUS or FFR, and if it is an isolated left main, as I said, can go ahead with PCI. And if the syntax score is less than 23 and high surgical risk and non-diabetic, you proceed with PCI. If it is low risk of side branch compromise after a main vessel stenting, then provisional strategy can be adopted. But if there is high chances of losing the side branch, you go for DK crush. This is the current recommendations. I will not go into the details for a short of time. And this is the heart team approach, which is absolutely mandatory for left main revascularization. You take into consideration the possibility to achieve complete revascularization, surgical risk, resource availability, and operator expertise, and patient preferences. CABG is preferred when there is low EF, concomitant cardiac surgery is required, doubtful depth adherence, including high bleeding risk, diabetes with multivessel disease, and anatomical aspects of left main plus 3-vessel disease and combined complex anatomy not suitable for PCI. What favors the PCI is urgent revascularization, serious comorbidities, high surgical risk and frailty, reduced life expectancy, anatomical aspects, ostial or shaft disease or left main plus only 1-vessel disease. I will not go into the detail of this particular site, but now syntax score up to 32, that is up to moderate severity, can be considered for PCI along with IVUS as the mode of intervention for left main. There are certain, this is the last slide, there are certain unresolved things. What is known as PCI versus CABGs, they have comparable risk for overall mortality and composite of death, MI or stroke in patients with low or intermediate anatomical complexity. Advantage of CABG is lower risk of repeat vascularization, more complete revascularization, especially in high anatomical complexities. The advantage of PCI is less invasive, shorter hospitalization, early mental and physical recovery, and lower risk of short-term morbidity. What is not known is important to note that PCI versus CABG, long-term treatment effects of CABG versus state-of-art PCI is not yet known. Long-term comparative of clinical outcomes between CABG and PCI in specific population like diabetes, heart failure with reduced ejection fraction, distal LMCA bifurcation lesion is still not known. Left main PCI, we don't know about the optimal stent strategy for distal LMCA, whether it is provisional stenting or 2-stent strategy, and optimal antithrombotic strategy following complex PCI, especially in Asian patients. Thank you very much. And I'm extremely sorry for going beyond the time. Thanks.